Welcome students to part 2 of our little look at articulations and body movements. So the first part of the lecture kind of focused on kind of more general information. This lecture is going to focus on 5 specific synovial joints that we're going to examine in a little bit more detail. So the first of these is the hip joint. So essentially what we're talking about is the head of the femur going into the acetabulum, the socket of the coxal bones. There are lots of ligaments associated with the hip joint. You can see, I think you can see it on this one here, yes. There you've got the little ligamentum teres right here, which has a blood supply for the head of the femur. And then you have very, very strong ligaments going from the femur to all 3 parts of the coxal bone. So you have pubofemoral ligaments connecting the femur and the pubis. You have iliofemoral ligaments connecting the femur and the ilium. And if we were to look at the posterior part of this, you would see ligaments going from the femur to the ischium as well. So we have ischiofemoral ligaments. The hip joint is very, very stable. The acetabulum is a really, really deep socket. There's lots of really strong ligaments, and in fact, when you stand up, these ligaments essentially act like the threads on a screw, and they screw the head of the femur further into that acetabular socket. And then not only is the acetabulum really deep anyway, but then you have this ring of cartilaginous tissue called the acetabular labrum, which essentially makes it even deeper and almost acts like a little suction cup around the head of the femur. So the hip joint is a ball and socket joint. It is multi-axial. You can flex, extend, abduct, adduct, rotate, circumduct, pretty much everything. But it is very, very, very difficult to dislocate your hip joint. If we look at the knee joint, the knee is actually the most complicated joint in the body because it's actually not one joint, but actually 3. We're talking about the lateral condyles and the medial condyles on both the femur and the tibia. So the lateral condyle of the femur connects to the lateral condyle of the tibia. The medial condyle of the femur then connects to the medial condyle of the tibia, and then we also have a joint between the patella and the patellar surface of the femur. So because this is such a complicated joint, there are lots of ligaments associated with this hinge joint. So it's a hinge between the femur and the tibia. It's actually a plane joint between the patella and the femur, or the patellar surface. So connecting the patella, we've got the quadriceps tendon here, is big stabilizing force right here, and then connecting the patella to the tibial tuberosity here is the patellar ligament. We also have what we call the retinacular ligaments, which are these ligaments right here, which branch off of the quadriceps muscle here and go to the 2 parts of the femur here, near the head of the head of the tibia here. We also have 2 collateral ligaments. So the collateral ligaments are really about preventing kind of side-to-side movements. So you have a tibial collateral ligament that goes from the femur to the tibia, and you have a fibular collateral ligament which goes from the femur to the fibula. We also then have popliteal ligaments. You have an oblique one and an arcuate one. They are in the posterior of the knee, and essentially, I'm looking at an anterior image here, but essentially what they do is they go from they connect the femur and the tibia, but they go at a cross. So it will start over here and end over here. It will start over here and end over here. Again, in the popliteal area, the back of the knee. Interior, inside the capsule, are 2 further ligaments, which really prevent the femur from kind of sliding on the tibia. prevents hyperextension of your knee. And these are the two cruciate ligaments. They also connect the femur and the tibia, and they cross inside your knee. So the anterior cruciate ligament goes from the back of the femur to the front of the tibia. The posterior cruciate ligament goes from the front of the tibia, the front of the femur to the back of the tibia. So they cross inside the joint between the femur and the tibia. So there are a lot of ligaments associated with the knee, which makes it fairly stable. The other stabilizing kind of force in terms of the knee joint, aside from all the muscle tendons kind of giving us nice taut tendons, are these two menisci of fibrocartilage. So you have these kind of moon-shaped fibrocartilage pads that sit on top of the tibia, between the tibia and the femur. Really nice kind of strong fibrocartilage because we're putting so much weight on our knee joints. If we look then at the shoulder joint, this is the other ball and socket joint in our body, but it is much less stable than the shoulder. What we're talking about in terms of the joint itself is the head of the humerus going into the glenoid cavity on the scapula. We have ligaments between all the different parts of the scapula. So you have a coracoacromial ligament that goes from the coracoid process to the acromion. But the two big ligaments, you can see you have that really are associated with the joint itself between the scapula and the humerus are the glenohumeral ligaments that go from the glenoid cavity to the head of the humerus. And then where is it? Is it on here? Yes, the coracohumeral ligament, which goes from the coracoid to the tubercle on the humerus. And the coracohumeral ligament is really like when you lift your arm, what's taking some of the weight of your upper limb is this coracohumeral ligament right here. So I mentioned that the shoulder joint is much less stable than the hip, even though it is also a ball and socket, in part because the glenoid cavity is much shallower than the acetabulum, although there is a glenoid labrum, so a little kind of deepening of the socket with a little bit of rim of cartilage, but generally, it's pretty easy to dislocate your shoulder. The other stabilizing force that the shoulder does have going for it, though, is the rotator cuff. So the rotator cuff is a series of 4 muscles, the subscapularis, the infraspinatus, dang it, I'm blanking on what the other 2 are. But they essentially, the way their tendons attach to the skeleton is that they kind of wrap around the socket itself, and that really helps kind of stabilize the joint, as does the tendon of the biceps brachii muscle, which is one of your arm muscles. It also has nice tight tendon. If you've got good muscle tone, helps kind of short up the shoulder joint. But it's pretty easy to pop your shoulder out of the socket. If we look at another hinge joint, we can look at the elbow. So what actually makes the hinge of the elbow is the trochlea of the humerus into the trochlear notch on the ulna, but then you have to remember that the head of the radius also attaches to the capitulum of the humerus, although again, what actually makes the elbow and the kind of the door-like motion of your elbow is the joint between the ulna and the humerus. If we look at the proximal radial ulnar joint between the ulna and the radius, we're looking at the annular ligament. That's essentially, starts here at the humerus, wraps around the whole head of the radius, and then goes back to the humerus on the other side, the ulna on the other side, and basically makes a sleeve in which the head of the radius can rotate. So this is a pivot joint, and this is the joint that is responsible for our ability to pronate and supinate. And then you have two collateral ligaments that help prevent side-to-side motions. You have an ulnar collateral ligament that goes from the humerus to the ulna, and then you have some radial collateral ligaments that go from the humerus to the radius. The most dislocatable joint in your body, so the least stable joint in your body, is the temporomandibular joint, or the TMJ, as it is sometimes known as. What we're looking at is a connection between the temporal bone and the mandible. So we're looking at the condylar process of the mandible into the mandibular fossa on the temporal bone. That fossa is really, really shallow. There's only one tiny little ligament, this lateral ligament right here, and that's it. Of course, we've got the capsule of the joint itself, and then that lateral ligament, and that's about it. So because of the lack of ligaments, because of the shallowness of the mandibular fossa, it is really, really easy to dislocate your TMJ. I mean, think about boxers, right? They get whacked in the face all the time. That's why they're getting dislocated jaws all the time. The TMJ does have a couple of like special movements that are kind of unique to it. It's a hinge joint, although it's a slightly little modified hinge, because it doesn't usually hinge joints basically flex and extend, but the TMJ doesn't really kind of do that. It does a couple different things. So really we're talking about opening and closing the mouth, so elevating the mandible, and thus closing the mouth, depressing the mandible, and thus opening the mouth. But then you also have protraction and retraction. So protraction is your ability to kind of like thrust your chin forward, and then retraction is like you can kind of like suck the lower jaw backwards a little bit. And then you also have kind of a side-to-side motion that your jaw can do, which is called lateral excursion. So if you were to kind of shift your jaw kind of horizontally, then you are doing lateral excursion at your TMJ. So those are 5 synovial joints that you can use kind of as exemplars of the other joints in the body.